Thank you so much, everyone. I am going to start with the slide above, if that's okay, Captain Noe. And this slide came out to the committee members about 2 days ago. It's in a PowerPoint, and I wanted to ask if you could walk us through.
Sure.
This.
Yeah. So this is some research that CDC has done over the years, and it really kind of demonstrates the discrepancy of reporting numbers of deaths during natural disasters. And what you have on the left are just different events that we've done, evaluations, and up on the top are the different agencies. And the first column is state response agencies, and this is what we're it's medical examiner and coroners and emergency management. And then you have Red Cross that does condolence visits. They collect data, and FEMA does a funeral benefits, and then National Weather Service has their own storm database that they report, and then you have vital statistics. And really from this, I can walk you through one, but really the point is that, all the numbers are different. And so, like the three things I mentioned that, could be the different case definitions, but really what's important, I think, is you look at vital statistics, and that is your official number. And what's happening is that we know that this is underreporting consistently through different events. And these are not really, there's some that are very large events, some that are not. And, I think one of the things that we did when we looked at this is really thinking through sort of the work process. And that's one of the things I gave the three, when they're filling out a death certificate, why would someone not put the event name on a death certificate they thought was related to the event? And really thinking through that maybe you're so busy you don't put it on, or is there an issue that different case definition, or maybe you just don't have enough information to determine if the death is related to the disaster. And that's why we created these three tools. But the other thing that I wanted to bring up that I think is important, I guess we're going to go into this question next, was the idea of what we want for real time. So we know that there is some delay in vital statistics, but I think that with the medical examiner and the EOC, and with Red Cross and FEMA and NOAA, at the end of an event, you typically, health departments will do an after-action report, and they'll have a meeting, and if there's deaths, even if there's 2 deaths or 1 death, or if there's 14 deaths, really these parties need to be in the room and talk about it, because if you have this discrepancy, that's where it can be figured out. And we know that in general, vital statistics is rarely invited to these after-action meetings at a state health department, and it's really important. Thank you.
So I have a second question to piggyback off this. We're fortunate at the table to have 2 federal representatives, 1 state and 1 local. So could the people on this panel tell me ideally how you would like to see real-time data interactions between these different levels of government?
I'm going to start that. How do we want to receive data? In my community, data sharing has gotten better. It has. I will tell you that the state has gone through great strides to centralize data sharing from epidemiology into hubs and hub distributions, but it's still an issue of getting some raw data from one jurisdiction to another, because I didn't tell you this, but the city of Houston has a health department as well, along with Harris County. So getting and sharing certain data points from them or from us to them is somewhat challenging. I think they can better streamline that process, and I think they're working towards it because they're moving into a centralized system. But in real time, getting hospitals, getting the medical examiner, getting our epidemiology folks on board with pulling or pushing data out. And let me go back to that pushing part. In our command structure, we assign a person for the science and technology and surveillance group, and that's their sole function, is to be looking for data points that didn't get reported or something that's happened, and maybe there's something slow in getting to us or information, and they make a reach out to that entity or whoever and tries to make a touch to see if we can pull some data from them. We did that a while back during Harvey because we were not getting data fast enough. So we put that position in so that we could focus one central person in trying to get data into us so that we can make decisions on the recovery side mostly about what was going on. Our EPIs were entrenched in doing their work, and unfortunately Well, it's just the circumstance we were under, particularly for Hurricane Harvey. We had to carve our epidemiology team out away from the department and put them in a mega shelter operation doing surveillance for a 10,000 bed shelter, plus a medical operation we had going jointly at what we call NRG Park. It's where the Houston Texans play. It's about a 800-acre facility with a NFL stadium and all that. So we were sheltering people. So our epidemiology department was spending so much time in shelter management epi work that we were lacking on somebody to do the research, to find and look at the data, to do analysis on it. So we built that position outside of epi and put a science person in there to start looking at that data. So I think just better coordination, better information sharing. Sometimes we have a little problem going up to the state and the state coming back, and we're working on that. And I think that's a good thing. I don't think we're there just yet, but it has tremendously helped us in the responses since Harvey, in not the federal responses, but the other responses we've had that I didn't mention in information sharing and data sharing.
If I could follow up with a Harvey story.
Harvey.
Yeah, because I think this was the first time it happened for us at the federal level. As I mentioned, we have medical teams out providing care, and even though our recording on the electronic record is not perfect, it's pretty good, and it gives us an idea of what's going on. And in Harvey, I don't know if it was the city or the county that asked us for our medical records. And they said, one of the reasons was because they were looking for people. They had people who were on, anti-tuberculosis medication that needed to be taken care of. They had people who were being treated for HIV who needed their medication. And it was, we had never been asked for medical records before. And so we had this huge debate about, can we give them identified records? Because, privacy and things like that. And in the federal government, there's a thing called a SORN, a Statement of Record and Notice. Whenever the federal government creates a database that has identifiable information in it, you have to make a public notice in the Federal Register alerting people that you have this privacy information in case people want to get it or want it protected. And we had never anticipated actually having to share identifiable data with anyone. Now, fortunately, I've also got a legal education, and I was able to blow enough smoke to our lawyer that eventually we just sent the whole kit and caboodle out. But it really was a weakness. And it's not just the federal government. There are multiple entities out there providing medical care and having medical records. And federal government doesn't accumulate these to do surveillance at the time. But the county and the city would, and they would be very interested. Now, I think we pointed this out in the after action report that perhaps we need to address this specifically and hopefully get it resolved. But we took care of it at that moment, and I don't know what's going to happen in the future. But it's a big challenge.
So I think just getting back to the points I was making about vital statistics and how those rules and laws do vary from vital records jurisdiction to jurisdiction. And if we're talking about real-time data and using that mortality and data, again, I can only speak to mortality data, but using that to respond to the disaster at hand and also prevent future deaths, again, depending on the jurisdiction you're talking about, it might not necessarily be death certificates. So in Texas, for instance, it's, you're not looking to state vital statistics to do your responses on the ground. You're looking at the data that's coming from, as in the case of Hurricane Harvey, out of the Harris County Medical Examiner's office, even before that death certificate is registered. However, there needs to be this feedback loop back to vital statistics because really that is the gold standard for mortality data. So at any point in the future, when people are looking at mortality statistics for public health response or policy and research efforts, you do want to ensure that at the end of the day, your death certificates, when registered, are consistent with the counts that have been reported up till then.
Yeah, and I guess I would add, like Texas, we know they do active surveillance using this one-page paper form, which I think is really great. They reach out to the medical examiners. Public health is collecting that data. I guess a question for Texas, and again, I know it's sometimes, with the information that's coming from the ME, it sounds like that goes up to the EOC, and public health is capturing some of the risk factors. How do you better streamline that? And I definitely think the electronic death registration, that's something that we're really trying to, well, as I said, medical examiner corner case management system and EDR, these are two systems that you could potentially use. The medical examiner case management system often has a lot of rich data that's not on the death certificate. And what I think at CDC, there's a lot of interest of, how do we move these systems forward? If we have barriers with laws, is there some evidence that would say you'd actually want to, maybe there needs to be some, thought about changing that, or kind of soliciting that to the fact where with drug overdose, we want to know that quicker than several days. So again, using preparedness to kind of start that conversation of how do we make things more quicker using these electronic systems, because having duplicative systems, you have an ME that's doing a system for the EOC and then maybe with public health, so it's sort of like doing it twice. And I think that we have talked about some, having redundancies is good, but sometimes as an ME, I imagine they're very busy, and trying to fill out a form could be very, difficult when they're really busy.
So let me see. Dr. Kilbane, could you tell us a bit about the role of the DMORT in real-time data?
We have DMORTs. They're teams of specialized people who may be in short supply during disasters. People like forensic anthropologists, forensic pathologists. They have expertise which, if there's a local event, you may not have those resources in your community. Now, what I like to tell people, and it's kind of heresy at my office, but DMORT primarily has its greatest strength is in identifying remains. Some people think that DMORT does everything in fatality management. No, the DMORTs are a collection of specialists. We have about 85 per team, and they can bring their examination materials with them. You set up an examination site, a deployable morgue, and they're primarily set up to do identification. You bring the remains in, the remains get put through a process, and at the end we come up with a recommended ID. In the meantime, we're also supporting an investigation. We're helping to determine a cause and manner of death, but of course we're federal. We don't sign death certificates. And I think that's one thing, if you don't know, in the electronic system, at least the state that I'm in, you have to have a state license to be registered to have access to that system. You just can't go to the website and start signing death certificates. You have to be enrolled. And also, even to put in demographic information, oftentimes you have to be a registered funeral director, mortician, etc. So it involves generating a death certificate involves multiple parties that have to be working together. The DMORTs don't do that. Of course, identification is very important. You can't really issue a death certificate without it. They generate enough information to let people know what they think the cause and probably manner of death is, although manner usually takes some kind of investigation, which further delays the data coming in. So that's the role of the DMORT, which is kind of minimal for generating the kind of information that I think you want about being disaster related.
I think that's helpful to hear, though, because I think there's often an impression that the DMORTs are providing this level of data, and I think having you clarify that is or how they contribute to medical examiners has been really helpful.
Yeah, and again, they generate a lot of information to support the local medical examiner coroner, but they aren't signing death certificates, and they aren't really making the determination whether it's disaster related or not. That's not really their function, although they may have an opinion.
Yeah, I did have a question about the DMORD. I was wondering also in Texas, and again, I think this is one area that I actually think we could leverage because they're often talking to families, and a lot of the families will have very rich data. I don't know in Texas if you have DMORDs of your own, and how that data being captured by. And typically, DMORDs are you have a mass fatality, and that's what they're going out to address. Do you have electronic system that you can put into the EDR, or how does that work? At least in Harris County, sorry.
Just let me also clarify. We also have a team, we call them the Victim Information Center team. They used to be called the Family Assistance Center team, but that was confusing because we don't do family assistance. But these are very trained, sympathetic people who will deal with the families in order to get identifying information that we can use to identify remains. So, and that really is a big part of the system to make it work efficiently. So those are people who can give us information related to the death. And that's one thing, and I've heard it brought up here. I'm sorry, I'm kind of deviating here. But we talk about, it's nice to have the medical examiner in charge of determining the death cause and the relationship, et cetera, as opposed to under normal circumstances, somebody dies in a hospital and their treating physician or treating caregiver makes that determination. The further you move that decision away from the caring physician, the more work it is for the medical examiner because they don't have the data that they need to make those determinations. So there's a trade-off there. It's nice to have one entity making the decision because you can get more uniformity in the standard. On the other hand, it's going delay, and there's obviously a transmission of data that's going to be required. In a medical examiner's office, sometimes it takes quite a few days, weeks to get all the medical records, et cetera, to determine what's going on. So there are pluses and minuses to that.
So the follow-up the question on Texas, yes, Texas has established a state-run DMORT system. It's strictly volunteers. They invested in the infrastructure, the equipment, the supplies, and the things that they need. There's one in my jurisdiction that's housed at our ME's office, and they respond upon request from Texas Department of Emergency Management down to the Department of Health, and then they will assemble and respond out. Our latest response, unfortunately, was the El Paso shooting. They responded out there and assisted with that community in whatever. I don't know exactly what they did. I haven't spoken to them after that, but I get a notice when they go out the door, and they went out the door to help them work through their issues in El Paso. So it's a plan that was put together 3 to 4 years ago. Recruiting volunteers to step up has been challenging, but they do have some core people now that can respond throughout the state of Texas if the need is there. There are other DMORT assets in the other larger jurisdictions, such as the Dallas, Austin area, San Antonio, that are there because we're so spread out. The state gave funding to get the resources in. We also use some federal funding as well to purchase some of those items, and they go around doing a great job of recruiting. They bring out their complete services and lay them out in lots of conferences and whatnot to recruit people to come in. but that is the current plan. Texas also has a not a DMAT team, but they have a emergency medical task force in regions now where it's similar to a DMAT team that comes in and assists and helps out from the medical side. I am a receiver of your federal resources during Hurricane Harvey, from DMAT and actually some DMORT services. We had conversation with them out at NRG, where I explained to you a while ago, and we greatly appreciate that. And we're thankful because we were somewhat drowning out there until they showed up. And I didn't mean that literally, but it's a figure of speech. We were above our heads in trying to get some of the care needed for the people coming into the shelter. Thank you.
If I could just speak to one of the advantages of having an electronic death registration system is that you're already, the Vital Statistics Office is already in constant communication with all of the data providers who need to use that system, because unlike paper, an electronic system, unlike paper, has controls in place for security and data quality, and as such, everyone has to communicate with us in order to get user accounts, training, just regular support for using the electronic death registration system. So to the point about Harris County Medical for the DMORT with El Paso shooting, so Harris County Medical Examiners went to support the El Paso County's Medical Examiner's Office, and so because they already know my field services team in the Capitol, in Austin, there was constant communication because we already do that in times of normalcy. We're already communicating with one another, so they already knew who to reach out to in terms of getting that support for filing the death certificates, and then we take that opportunity to remind them about referencing the disaster on the death certificate. So that really helps too, and in terms of increasing the number of death certificates that report the death in relation to a disaster. Just already having that communication support network in place. That is just, if you want an electronic death registration system to succeed, you have to have that already in place.
Yeah, and one thing I'd like to add in terms of Texas, they have a terrific Funeral Directors Association there that's very active during disasters. And the point being that the vast majority, I believe, of electronic death certificates get initiated by the funeral directors. And I don't think we've mentioned that yet, the vital role funeral directors play in this whole process. They put in the demographics most of the time. So if the funeral industry is not working during a disaster, that's another potential delay.
So I'm going to open it up to committee members now and start with Dr. Stoto.
Well, thanks everyone for those nice presentations. They're really very helpful. I was really struck with something that Max said about how there are hundreds of people in the EOC all looking for data to save lives, so they can do something differently to save lives. Right. And so I guess my question is, what are the kinds of decisions they have to make, and what data do they need for that? Like I can imagine, is it where should they put a shelter or things like that?
Yes, Dr. Soto, that's correct. So I will take Hurricane Harvey for an example, because we were locked in with water. There were people that had resources and people that did not have resources. It was widespread, and we didn't know exactly. We needed reports coming in from EMS providers, hospitals that were receiving, that could not receive, to figure out what to do with those people. So what are their conditions? Are they just wet, or do they truly have medical conditions that need medical attention? Because remember, I just told you we had a field hospital set up with NDMS out at NRG. We could make a decision to transfer that person from the field via helicopter or boat, or whatever we needed to do to get them over there so that they could get the medical care that they would not receive out in the field from an EMS provider and or a hospital that's offline. Well, nobody went offline, but they just were not receiving because they had water. Right. So those decisions were being made real time. So that was real communications coming in that we were trying to work through, trying to figure out where to pick and put these people to get them. We went from water to lily pads to landing pads is what we call them. From water to dry to somebody and then we didn't keep them very long. NEMS didn't keep them but more than a day, and then they were transported out to somewhere else in the state of Texas that had a hospital bed somewhere, and that's the path of communication and data we needed to figure out the best care for the person that was coming in. And then our governance at the time opened it up not just to Harris County, but the whole region. So now I have people coming in from Sabine Pass, Corpus Christi, places like that we have no records of whatsoever. So the back communication has to take place with the state of Texas so that we could tie all the points together to make sure they get the appropriate care, because honestly, we just did not know what was going on. We were trying to do the best we could. So the quicker the data came in, the better decision we can make for the outcome of the patient coming in at the shelter operation that was going on. I will tell you, I can't remember who asked the question a while ago in a disaster about morbidity or mortality. It was kind of, which do you think? It kind of goes hand in hand, but I'm really looking at that morbidity data about what I can do for those people who have survived to bring that curve down. The quicker we can bring it down, the better we get back to normal state of business. So that was kind of my answer I wanted to throw out a while ago, but I didn't get a chance to.
So to follow up on that, I mean, it sounds like what you need data on living people primarily, and what they need and where they are.
That's correct. Right. Absolutely. We need to know, and where we're going to place them long term, because we can't keep them. We're just trying to get them to a place, get them evaluated, get them looked at, trying to find out what they need. If they could go into the general pop shelter, that's where they went. If they could not, we had to move them out. We can't do long-term care. That's just a field hospital with limited ability. We've got to get those patients into somebody who can give a better care to them.
Could I also follow up with Dr. Kilbane about what questions the federal government needed answers for? Like, I can imagine, do we need to give disaster assistance? Is it a mutual aid situation, or I don't know what?
Well, a lot of those questions are dealt with not at our operations center level. I mean, that's a negotiation that occurs with the state.
Yeah.
So I can't really tell you because I don't get involved in that.
The only one I would say that probably it's not a hard, fast rule, but typically 100 deaths usually sets an alarm of a DMORT. That's sort of the number I've heard. I don't think it's a hard, fast rule, but that's when you're going to get federal resources. And I think one of the other things that I know Oklahoma will be talking that there was some miscommunication during some tornadoes, and the media reported more than 100, and the DMORT got called. And we verified with 3 different people that when a DMORT gets called, it's $1 million a day asset. And so if you got the number wrong initially about what's happening, it's a very expensive proposition. So it's really important for that initial step, having a good understanding that, how severe is this event?
So is it at the level that's likely to require federal assistance? Right.
So that would be at the state, it would be at the count, very local, then state, it would go up that way. And if I think now, and I apologize, Mac, you have to correct me if I'm wrong, but with the local level, if they want to request a DMORT, then they would go to the state, and they would do typically mutual aid first. An EMAC, they would go to a mutual state because it's quicker, and then if they need assistance with the federal government.
Yeah, and I mean, I've been with the system now 7 years, and so far the DMORT has only been deployed once, and that was to Puerto Rico, and it wasn't to operate as a DMORT, it was to provide supplemental staff and supplemental equipment. What I've tried to do is, instead of just sending a DMORT whenever anyone died, is now to send an assessment team very rapidly within hours with a procedure that they can go through to assess what's needed, and then we can get them what they need, whether it's part of a DMORT, a certain specialist equipment, more bodies to collect bodies, whatever it is. So historically, if there's more than 100 remains, generally someone's going to call us. It's not a trigger, that just is historical fact. Or if the local authorities can handle the overload in 5 days of overtime work, then they generally don't need our help because it takes us at least 3 days to get there.
Yeah. So it's not our role to question what these policies should be, but the question really is what data are needed to answer these questions.
For mortality, it's a number. Yeah, initially. And sometimes the initial number is wildly off.
Is it fair to say the different states have very different thresholds for requesting assistance? And Mac's nodding his head. Generally, Texas says just send us the check, we'll take care of the rest. Because you've got so many resources and you're used to doing that, whereas other states there's a much, much lower threshold for requesting DMORD assistance. But I think we've got to be a little bit careful because we're getting into essential elements information here that when you're in a emergency operations center and you're trying to reduce morbidity and mortality, you're overlaying inundation zones and power outages and potable water and EMS calls and hospital volumes and everything else, and trying to figure out on the front end how do we reduce morbidity and mortality. I think what we're looking at is how do we categorize the effects of that from a morbidity and mortality standpoint and then learn from them to try to mitigate future events. And Mac, you guys did a phenomenal job between Tropical Storm Allison in the Texas Medical Center flooding that occurred as well as the community flooding, between then and Hurricane Harvey, which dumped a ton more water on you guys, and yet everything stayed afloat, functionally, literally, and you guys really did an amazing job managing that, thanks in great part due to all the good learning that came from Tropical Storm Allison and the expense of mitigation activities and the time that you guys put in.
Those mitigation efforts that the Texas Medical Center put in play, and actually other hospital systems that followed by raising their generators, raising their fuel tanks, putting in the tunnel in the submarine system, locking the water out and keeping it out. During Harvey, they couldn't get patients to them. But as soon as the water went down, they were back open for business. They were. And that helped us tremendously on our resilience and our getting back to our normal state of doing that. So those efforts that were put in play, those dollars that were spent, were lessons learned from years past, back to Allison, some of the hurricanes that we had coming through. So we've learned our lesson a little bit. I just wish we would learn our lesson a little bit, how to share data better to get some results done in a more timely manner, so to speak.
And consistency of data, as I understand, and this was thanks to Rebecca from the CDC, but there are certain jurisdictions, including yours, that don't report indirect disaster deaths. So if you were looking at these numbers from Harris County, but also looking at a different epidemiologic approach to disaster deaths, you'd have a very different number, and obviously that's going to create some confusion. I find one of the biggest challenges we have, at least during the heat of an event, is vetting data. We have numbers that sometimes seem wildly off, and sometimes it's because they are wildly off, and sometimes it's because either the wrong questions being asked or a different set of data is being provided in answer to that question than somebody else's data set.
I guess the other thing, and we'll be talking about tools later, but I did want to say we talked about granularity in an earlier panel, and the fact that, we know that, again, the DMORD collects these antemortem data. They talk to family assistants, also scene investigation if you don't have a DMORD. That's where a lot of the granularity, where the medical examiner, they have a case management system, so that's where a lot of the granular data is. And the death certificate is less granular. I think that for real time, they're, again, really interested in strengthening medical examiner coroner case management systems so they can report data in electronic fashion, because there are medical examiner case management systems that are a file, drawer, and a piece of paper. So that's a problem if you're trying to report. You might be doing a line list, and then how is everybody, what variables are we using? So again, trying to support medical examiners and coroners, but again, then trying to put it into electronic death registration, because we know that's electronic, and whether we're putting in a flag or an alert to make that so that the data is more accurate.
Dr. Khan?
Thank you very much. I think my biggest takeaway from this panel is there's 50-plus systems in the United States. There's not one system, which obviously will make a challenge as you think about recommendations. But let's go to, if I can ask a question about Texas. So number one, in Texas, it looks like 30 people died twice, according to what they reported to FEMA and what they reported to state. Just a comment about Texas. But so in Texas, how do you deconflict this data? Is there a way to deconflict the data to say this is how many people died during an event? Because you have reporting from multiple different agencies?
My suggestion really is, so just again to walk through this, I mean, you have that initial reporting, right? And you just, again, we know it's messy as best as you can. Your MEs are reporting that. And then you have, it goes to the operations center. Again, how is that data being reported to the emergency operations center, I think is important. If it's a line list, someone has to analyze it, and there have been instances that we found that, you know, different people like PIOs are analyzing that, public information officers are analyzing that. So that's kind of your initial report, and sometimes that's emergency management. You know, they get the number from MEs, and that's what they hold on to, and that's what they would report. And then you have Red Cross doing condolence visits, and you have FEMA. People apply for funeral benefits, and typically FEMA says, fill it out, even if your family member hasn't passed, because just fill out the form. And we know from multiple events that there's usually, you know, I mean, like I know in Sandy, there was 250 or 300 applications. So they're getting over representation. And then National Weather Service, they call the emergency manager for the number, and it goes into their storm database. And Congress uses mostly that number. We just had an experience with a report. They use NOAA data, which is from emergency manager, which may not be the same time frame. And then you have vital records. So I'm thinking in an event, you know, you should be, somehow there needs to be some active surveillance. You know, we have the Public Health Emergency Preparedness Program that talks about epi-surveillance, talks about fatality management and information sharing. We have elements in there. People should be doing morbidity surveillance and mortality. And public health should know what's happening mortality. They may not do it. I mean, there's some states, Texas is doing it, but the ME's doing it. What is the case definition? What are they, you know, if we don't have any carbon monoxide deaths in Harris County, you know, 5 days after the event, and they don't they don't register indirect, I shouldn't assume as the state epi that is actually okay. I should go probably look at my poison center data to see if I'm seeing any carbon monoxide poisonings. But I think these disparate numbers at the after action meeting, you know, emergency management center, and think this is what the ME has reported, and the ME probably doesn't come because they're super busy. And you know, same with, you know, so I think the fact that having them at the table, and when you have this disparate numbers, we have these tools now, they figure it out. They can't call CDC, you know, figure out what is the number. And I think, you know, there'll be probably a lot of easy things where, you know, on the vital statistics, oh, you forgot to put the event name. And just adding that to and adjudicating those death certificates and having a report that has what's reflective in vital statistics. It's not going to be perfect, right? You know, there's going to be some discussion, but a little closer.
So that was excellent, thank you. And I don't really, to be very honest with you, care what that final number is as opposed to the communication that gives.
But people do. I mean, because they get their FEMA benefits.
But you know, it could be 20, it could be 104, it could be 38. But how do you get people together to sort of have that conversation about what that number is, and more specifically, real time? So yes, there's this after action report that people sit around and decide this was what the number is. But real time, you two in Texas, what are you doing where you're seeing data coming in from multiple sources to say this is what we think is going on in our community?
So I'm not seeing that data. That's the ME's office seeing the data. So
You don't see it.
at the break, I actually called them to have a quick call discussion with them. And under current Texas guidelines, they're telling me that it is somewhat confusing. It's not kind of black and white like Florida is. There's some opinion in this that they have to make. And actually, they've been working with the state of Texas trying to resolve that, trying to figure out what actually has to be reported. So they're still working on that. So the medical examiner's office in our county, it determines whether that was a storm-related death or a post-death for whatever. And that's all we have. Now, it does change as information comes in, numbers go up, things like that, but it is their sole responsibility to analyze that data, put the death certificate together, and move it forward. We're the conveyor of the information to the elected officials. That's all we're doing. They're doing the reporting.
Do you get a line list from the ME, or do you?
I don't, epidemiology does, and then they
Okay.
report to me what's going on, and then Dr. Shaw and myself and others sit down and we take a look at it to see if there's something we need to be doing.
Right. And I think in FEP, we're trying to encourage people to come together and have, before and after action, we want to have that meeting before, sort of understanding these gaps and being able, and I think in Texas, they're doing active surveillance as well with that. And I think it's partly because being able to collect more information, sort of the granularity that you're talking about. I don't know if you want to talk about that, Tara, sort of the active surveillance that's being done in Texas.
At the state level?
Yeah.
I mean, yeah, as I mentioned before, with the vital statistics system in Texas, by statute, death certificates must be registered within 10 days of death. That's a really long time if you're thinking real-time mortality surveillance. But at the same time, we work very closely. I mean, partnerships, as was mentioned during the Florida panel, what can you do without partnerships? And so having come from New York City, coming to Texas, that was something that was very important to me, was to cultivate those partnerships with my FEP colleagues at the state agency. And so during Hurricane Harvey, for instance, we had already established that partnership. And, death certificates during real-time mortality surveillance in the state of Texas is just but one source of data. I know that our disaster epi colleagues were looking not just at death certificates. They were working with us to doing in terms of doing proactive outreach to the medical examiner offices and hospitals. They were looking at media, including social media reports, and using all of that in addition to that one pager, that disaster-related mortality surveillance form, using all of those things together. As I said, I think that working together to try to get that data back into the death certificates is really important, because that is the official record on death data. But is there anything else that you want me to mention? That's really it. I think in terms of real-time mortality surveillance, again, in Texas, death certificates is just but one source. It was different in New York City during Hurricane Sandy. We worked very closely with the medical examiner's office, and because all those deaths were medical examiner's deaths, and they have to be medically certified within 24 hours, just much more conducive to real-time mortality surveillance. And so you're not having to necessarily triangulate amongst multiple sources of mortality data. As you mentioned, it differs you're dealing with multiple systems if you're thinking about sort of not just the state level, the county level, and the city level. Dr.
Cases they weren't medical examiner cases they were.
Oh, I'm sorry. Can you repeat that?
Sorry, I just want to make sure I clearly understood. Did you say that the New York City medical examiner considered all of the Sandy cases medical examiner cases, or that they weren't all medical ME cases?
Yeah, and I see one of my colleagues from the medical examiner's OCME as well, so he can correct me if I'm going to say something wrong. But I remember during Hurricane Sandy in 2012, we had put up, because New York City also has an electronic death registration system, and so in communication with the Office of Chief Medical Examiner, the pop-up notice that we put within the system, and Texas has the same thing. We have the ability to put up pop-up messages for anyone completing the death certificate. The pop-up notice for Hurricane Sandy was that to all medical certifiers, if you believe this death was due to Hurricane Sandy, stop with the death certificate and refer it immediately to OCME.
Thank you.
You're welcome. But that was something specific messaging that the New York City leadership had wanted.
Dr. Vanderwagen. Thanks for waiting.
Good conversation.
Yeah.
And I don't know exactly where Mike was going, and I think John covered a lot of what I was thinking, but Mac, as I was sitting listening to you and so on, and knowing what we were doing over on the HCA side in Houston during that period of time, et cetera, individual patient information is critically important to the operators in the event. Who needs to be sent to where, and what are the logistical requirements to support that movement? From an overall planning perspective, as John pointed out, that is probably, that's a loggy challenge that somebody's got to deal with. But if you're sitting and looking at the big picture, your anticipation is going to be built around weather patterns, road blockages, et cetera, et cetera. And really the aggregate patient information of how many people are appearing who need hospital movement becomes the aggregate number you're interested in overall during the event. Yes, you got loggies and operators moving patients and taking care of all that, But if you're overlooking the operation, you're interested in what's the big number looking like and what's obstructing me from moving them or taking care of them or whatever. I mean, for us, we had 15 hospitals that were water bound. And, you know, did they have adequate supply? I mean, that's a big aggregate patient population. 250 people here, 250 people there. Do they have enough supplies? Can they sustain their staff? Is there food? Is there water? Those are aggregate patient information in an operation that becomes important if you're going to sustain that asset and not have to conduct an emergency rescue. And as you know, we were using duck boats and a variety of other things to make sure that the nurses had the food that they needed, et cetera. And then you've got the whole business of how many of those nurses now have blue tarps on their house, and where are you going to find replacements for? Now, that's a different kind of data flow, and John, that goes to your point that there's a whole lot of data flow that's going on there that isn't limited to sort of patient information per se. So I'm on board with you, and I think, you know, we've sort of tried to tease out what's the aggregate data you need from a patient perspective, knowing you need individual data, but our interest is aggregate data issues.
Sure, understood.
Dr. Wynia?
I hope this is a sensitive question, or not a too sensitive question. I remember a couple of years ago, Sherry Fink did a piece in the Times about the aftermath of Harvey, tracing an individual patient who had a post-op complication and died, and presumably was not counted. And if I recall at the time, she said something like there was an excess mortality across the city that month of 200 people, and that the mortality statistics counted 35 or 40 or something like that. And I've heard twice now that the choice is not to report indirect mortality. And I don't know, I don't want to ask you whether you think that's a good choice or a bad choice, but I am wondering, for the purposes of our work, could you articulate the best possible argument for not reporting and tracking indirect mortality after an event? What's the best argument you can think of for that?
Honestly, I don't have an argument for it, because if it's related to the event, me personally, I feel like it should be reported. But I don't get to make that call. That's the medical examiner's office that makes that call. So I don't have a good answer for you there on that question. I just don't.
There must be an argument for it, because it's happening. So what's the political argument for it even? I'm just
the political argument, and there maybe if there's financial considerations too. I think the political argument is just you want the event to appear the less impactful the possible.
It's partly manpower.
I mean, there is a financial decision, but I think sometimes we like to ascribe causation where there really isn't any. You know, if the system isn't set up in such a way that it tends to make people do something out of the ordinary, like ascribe it to a disaster, they're not probably going to do it. And even the medical examiner may not be the exact best place to make that call, witness the excess mortality. As a researcher, if I'm looking at an event, excess mortality is a logical place to go and hard to argue that shouldn't be the number that we look at. And if you want to make a policy difference and try to understand what the ramifications are so that we can change things theoretically, then I want to know that excess mortality, but you're not going to capture that in real time.
Mm-hmm. Right. So, I guess the only thing about excess mortality, you still won't be able to, which is the excess. You can't tell, like, do they have, is it, I mean, carbon monoxide, you know. I mean, I think they're, you know, probably I think that's why we did go ahead, sorry.
Well, no, I mean, it's a fair point, but you know, until we realize that there is excess, we're not going to start to look into it and figure out what it might be.
Yeah, we have two other questions.
So, Aram, it's at two different levels, I think. So, yes, there's this excess mortality that we can't have difficulty attributing currently, but there is well-defined definitions for direct and indirect. And some jurisdictions choose to just count direct, whereas other jurisdictions do also count indirect based on easy answers to indirect.
And that's fair. My point also, though, is that the excess mortality is still probably bigger than the direct and indirect.
So we
have just about 5 minutes left and probably time to get to Dr. Frankenberg and then Dr. Rothwell, and then we're done.
So it sounds like there are a couple of sources of information on morbidity that you all have access to that I don't think I had realized that were there before. And one might be what kinds of treatments are being provided by people who are being brought into either hospitals but also shelters where it's your teams that are responding and trying to provide that. And then I guess Dr. Cobain, you mentioned that there was also a DMAG that was a federal level response to go to places, I think, and provide health services that didn't generate an electronic record that you guys end up with, or a paper record. And both of those sound like interesting data sets on real-time morbidity and treatment that might complement some of what we're trying to do on mortality estimation. So if you could clarify whether I've got that right, that would be great.
Well, DMATs, the Disaster Medical Assistant Teams, we have, I think, currently about 4,500 people that we can mobilize, medical professionals, and send out for 2-week periods. We pay them. They aren't volunteers, but they aren't making any money either, so they aren't making a big profit. And we have records, paper or electronic.
Right. And then I guess for Harvey, you probably ended up with a set of records
Yes, ma'am.
from the shelters that also covered some of that.
Yes, ma'am. Let me explain to you a little bit about that shelter operation out there. There was a community effort to bring in Harris County Medical Society and some other physicians by our governance at the time to interact with us and do the triage and treatment at the shelter operation over there. And to my knowledge, I'm not sure where those records were kept electronically. I think it went to our county system. I'm not real sure, but we were told to focus in on the health of the shelter and the operation across the street, which was the NDMS pulling in patients. So I'm not sure it's all accurate, is what I'm telling you. What we have is accurate, but there may be other medical records for the clients coming into the shelter that we don't have information on because it was not done by us, it was done by NGOs. And I know they were doing paper records at one time because they had no computers over there. But I think they brought in an electronic system at some point in time, but that would be with the county hospital district system, and they would have those records, but we do not. So to answer your question, no, they're not all encompassing, probably need to be, but we don't have them.
I just wanted to add to that. If you do a search of PubMed for DMAT or NDMS or even American Red Cross data, which American Red Cross seems to be, because they're running the sheltering operations, seems to be like it would be a great source of data. There's virtually nothing in the peer-reviewed literature using those sources of data. Dr. Rothwell?
I guess this is to Tara, but first of all, Texas is lucky to have you, and you're in a unique situation in that you were in one of the first EDRs, and I think one of the better ones, and now you're in a different EDR system under different legal requirements, and so you have a unique perspective that you need to think about and maybe provide us offline with some of your comments. But there are several things that's come up in this group and the former group that has my concern. One is in the former group there was a comment, I think, in Florida that we need to only enter information in one time, either from the medical examiners and or into the EDR, which means that you need to be able to share information. And then there's the issue, I think I was hearing that maybe you can't do that in some states because that information can't be shared. Then I heard from you about the New York City capability of putting up the flag, saying that, I'm sorry, you can't complete this if this is related to an X disaster. The oldest model law in the United States is the vital statistics law, and it's been updated, by the way, more times than any other model law. But it doesn't relate anything to, in my knowledge, about disaster, who should be sharing data, and how they should be working together. And it doesn't say anything about how that information should be collected in a disaster time. In other words, requiring EDRs to operate in a certain way. What do you think?
First of all, thank you so much for your comments. If nothing else, because they made me look good, so thank you for that. It was really interesting. It was almost like providential in a way, having gone through Hurricane Sandy in New York City, and that was just a unique set of circumstances. And I'm also looking to Dr. Schwartz, who was the New York City registrar at the time and was my boss, so I have to call him out. But that was really interesting also because it kind of speaks to what Mr. McClendon was talking about when you're in a locality in New York City, unique, not only being a locality that was going through the disaster, but also being an independent vital records jurisdiction and responsible for the registration of official death records as well as birth records. And that was a very turbulent time because we had to evacuate. Our offices are in Lower Manhattan, and that's, was really impacted. There were power outages. They run a 24/7 death registration shop. Someone was caught in the building when Hurricane Sandy hit and the power went out. So it was having to maintain, getting to vital statistics, and the idea of really, yes, we are here to support public health emergency and disaster responses, but we also have to make sure that we are maintaining continuity of our operations. And vital statistics operations are very unique. Not only are we supporting public health response with mortality surveillance and that count being accurate within death certificates, but we're also ensuring that the registration and issuance of these records can continue. Because it's in times of disaster, just as in times of normalcy, we talk about vital statistics being used not just for public health purposes, but legal and administrative purposes. And during times of disaster, people really do need to replace their personal records, being birth records, or they need to make sure that those death certificates are being registered timely and make mention of the disaster so they can get those benefits and support services, which means that's incumbent upon that vital records jurisdiction to maintain continuous uptime in operations. So in New York City and also in the state of Texas, I've just been very fortunate to have that support of leadership where when you're talking about electronic death registration system, it is very useful in times of disaster so that you don't have to rely on paper-based records that may or may not make their way to the vital statistics office. But in having an electronic death registration system, as we talked about, power outages and other such issues. But if you have the support of your leadership and being on the radar for continuity of operations, in New York City it was 0 recovery time objective. In Texas it's 12 to 24-hour recovery time objective. That means that we get priority over many other systems when systems go down. So in New York City it was like, as soon as the commissioner had his BlackBerry working, we were next in line to make, and we had during Hurricane Sandy, there were ups and downs, and with everything, things being so turbulent, just the memories are more vivid because we were right in it with everyone else and having to evacuate, set up shop again. But during those times, electronic death registration, you just see the advantages of it more and more because everyone knows where to go to get to that system, but then you also have to have the support of your leadership and IT to have that priority to keep the system up as much as possible. So to your point about it being included in model law, I think that's a fabulous idea because there are so many considerations to balance, and there hasn't, I think for me personally, just having been in these two different vital records jurisdictions and having gone through hurricanes and having those experiences in the vital statistics office being very different, I think there needs to be more discussions around it.
Would you be interested in being involved in such a thing?
Yes, sir, I would. You're all my witnesses.
We are well over time, so Dr. Bernard, do you want to ask a quick question or?
No, I'll just make one quick point to
that all the systems we've been hearing about today in Florida and Texas are a level of their own above anything we do have internationally. The January 12, 2010 earthquake in Haiti, to this day, the number of dead ranges from 85,000 to 316,000. And we don't know any better than that. So thank you very much.
Hey, Dr. Fierro, I'm sorry I didn't see yours. Do you want to say something quickly?
Just a quickie comment on the difficulty of determining those, or why some jurisdictions don't count those indirect deaths. An ordinary indirect death where, say, John Brown cuts himself with a chainsaw while he's trying to remove a tree from his roof, he gets captured no matter what, whether he gets classified as an indirect death or he just goes into their ordinary classification of accidental death. The problem with the indirect deaths is the subtle ones. Is John Brown, who dies in his easy chair a half hour after working outside to clear debris to exhaustion, and then comes in and sit down. He's not likely to even be captured. He's got a history of heart disease. He's sitting in his easy chair, he dies. You and I know he's an indirect death fitting the definition, but the chances are he will not be caught. Or the fellow who is found in his apartment who lives alone during the heat wave associated with the hurricane. He's not likely to be captured either, but he might be if someone thinks he's a hyperthermia death. So this becomes a very fine matter of judgment depending on which physician or which EMS is making an assessment of the circumstances surrounding that death. Some of these guys won't even get reported to the ME to include as an indirect death. So, and it becomes, if you're in New York City, you're talking about thousands of people. Then it becomes money, manpower, and logistics.
Thank you so much to the panelists. Thank you to everyone for the great questions and discussion.